I'm Dr. Chris Aiken.
I'm Dr. Greg Malsberg.
And I'm Kelly Newsom, a psychiatric NP.
And this is Carlat Psychiatry News, where we give you the biggest psychiatric updates for the month.
A recent study in the American Journal of Psychiatry brings us important news about psychiatric risks with amphetamine stimulants. The researchers analyzed data from over 4,000 patients who were admitted to Harvard McLean's Hospital. They ranged in age from 16 to 35, and they found that those prescribed amphetamines in the month before admission had a higher risk of developing psychosis or mania. The findings are striking. Patients were 3 times more likely to develop psychosis or mania on amphetamines compared to those who were not on them, and that risk was 5 times higher if the dose was above 30 milligrams dextroamphetamine equivalents, which is the same as about 35 milligrams for Adderall or 80 milligrams a day for Vyvanse. Now, this wasn't a randomized trial, so it's possible that amphetamines were prescribed to those with more severe symptoms to begin with, but the dose-dependent relationship strengthens the association, as does another finding from the study. There was no increased risk from psychosis or mania with methylphenidate stimulant prescriptions. And on a biological level, there is a known risk of psychosis with amphetamines, and this study reaffirms that. Amphetamines have been used as animal models for psychosis and mania, highlighting their potential to induce these states. What this means is that you got to be careful when prescribing amphetamines to people who are at risk for mania or psychosis, such as patients with bipolar disorder or psychotic depression or other psychotic disorders. And you got to be especially careful when that dose goes above 30 milligrams dextroamphetamine equivalents, which, by the way, is similar to the dose cutoff found for problematic side effects in a recent meta-analysis of stimulants in ADHD. There are a lot of psychiatric risks with stimulants to know about, and many of those risks differ between amphetamines and methylphenidate. To learn more about them, check out our Carlat webinar called Amphetamine versus Methylphenidate, which delves more into these risks. The bottom line: avoid amphetamines like Adderall and Vyvanse in patients who are at risk for psychosis and mania. Now, methylphenidates might be safer here, but keep in mind that other studies show that they too have a similar risk.
A new paper from the Mayo Clinic proposes an updated algorithm for selecting antipsychotics in schizophrenia, emphasizing a shift in initial treatment recommendations, particularly in cases involving aggression or violence. The review recommends clinicians classify schizophrenia patients at diagnosis into 2 categories: those with and those without aggressive behaviors. For patients with a history of violence, they advocate starting with olanzapine, citing its superior efficacy in managing hostility in multiple studies. If olanzapine fails, move next to clozapine. This is a big change, as existing guidelines recommend 2 antipsychotic failures before trying clozapine. Here, they are moving it up, but only for patients with a history of violence. Why? Because clozapine's superior efficacy may reduce aggression sooner in the treatment sequence. The recommendation is in line with the APA Guidelines, which highlight clozapine's benefit in aggressive and suicidal patients. For non-violent cases, the algorithm now includes olanzapine and perfenazine, along with aripiprazole and risperidone, deviating from other guidelines that generally exclude olanzapine due to its metabolic risks, and perfenazine because of side effect concerns. But despite metabolic risks, olanzapine has an efficacy advantage over the other antipsychotics, and patients stuck with olanzapine the longest in the pivotal CATIE trial. Similarly, perfenazine's lower rates of tardive dyskinesia and effective symptom control support its place as a viable first-line option. The guidelines place importance on long-term outcomes, such as all-cause discontinuation and mortality, rather than focusing on short-term side effects. This aligns with studies showing lower mortality rates for clozapine and olanzapine users compared to some other antipsychotics like risperidone, particularly in extended follow-up studies. These criteria aim to balance the need for effective symptom management with long-term patient health. These new recommendations aim to address gaps in current schizophrenia treatment practices, especially for patients presenting with violence or high hostility. By placing olanzapine and clozapine earlier in the treatment sequence for aggressive patients and expanding the first-line options, this algorithm may offer more robust support for clinicians in both managing symptoms effectively and minimizing early discontinuation. With these recommendations, clinicians are encouraged to engage in shared decision-making with patients, aligning treatment choice with individual symptom profiles, tolerability, and preferences, while monitoring for metabolic effects where indicated.
Have you ever found yourself obsessing over your sleep tracker data, striving for that perfect night's sleep? If so, you're not alone. With sleep tracking devices becoming a staple in many of our lives, a new phenomenon called orthosomnia has emerged. While it's not officially recognized in the DSM, orthosomnia describes when people become overly fixated on achieving ideal sleep metrics. There was a recent study published in Sleep and Biological Rhythms that brought some valuable insight. Researchers have developed the Anxiety and Preoccupation About Sleep Questionnaire, the APSQ, to help identify behaviors associated with orthosomnia. This tool measures two main areas: concerns about sleep quality and a perceived lack of control over sleep. In a review of 4 studies involving 2,506 participants, the APSQ showed high reliability, with consistent results across different cultural contexts. This suggests it could be a useful screening tool to spot when someone's preoccupation with sleep might be affecting their well-being. So why should we care about orthosomnia? While keeping an eye on sleep patterns can be helpful, becoming too obsessed with the numbers can actually make sleep problems worse. People with orthosomnia might experience increased anxiety, leading to disrupted sleep, and a vicious cycle of trying harder to achieve perfect sleep and sleeping worse as a result. So as clinicians, it's important to recognize when a patient's use of sleep technology is doing more harm than good. The APSQ can be a helpful tool to assess whether someone is becoming too anxious about their sleep data. While orthosomnia isn't an official diagnosis, understanding these behaviors can guide you in offering balanced advice. You might consider encouraging patients to use sleep trackers as general guides rather than strict measures for success. So focusing on how they feel rather than just the data can help reduce anxiety and improve sleep quality. In our tech-driven world, it's easy to become overly reliant on gadgets and data. Reminding patients and ourselves to find a healthy balance can make a big difference. So sometimes the best approach is to listen to our bodies and prioritize relaxation over perfection.
The American Psychiatric Association has released updated treatment guidelines for borderline personality disorder, highlighting psychotherapy as the central approach for both adolescents and adults. The new guidelines move away from pharmacological treatments that have shown limited effectiveness for the core symptoms of BPD. Dr. George A. Keepers, chair of the APA Practice Guideline Writing Group, noted that since the last update, research has demonstrated that several forms of structured psychotherapy are effective for BPD. However, no single approach has emerged as gold standard. Importantly, there is no evidence supporting the effectiveness of any medication for treating the disorder's core symptoms. As a result, the new guidelines emphasize psychotherapy as the core of treatment and aim to limit unnecessary polypharmacy. So what are the key recommendations? The updated guidelines outline 8 core recommendations, most with low level of confidence, including the following highlights. Clinicians should conduct a comprehensive evaluation of psychiatric symptoms, treatment history, and physical health, as well as assess suicide, self-injury, and aggression risks. Patient treatment goals and cultural factors should also be reviewed. A person-centered treatment plan should be developed with the patient, ensuring psychoeducation and shared decision-making about the diagnosis and treatment options. Here's the only moderate confidence recommendation. Treatment should include a structured psychotherapy approach that targets core BPD features. Regarding medication use, they recommend limiting psychotropic medication treatment durations and ensuring these treatments address measurable symptoms and are adjunctive to psychotherapy. Review and reconcile patient meds at least every 6 months to assess their effectiveness and and identify those that can be tapered or discontinued. Why this matters? These updates reflect prioritizing psychotherapeutic interventions over medications. The move towards psychotherapy first treatment aims to improve outcomes for patients with BPD while reducing reliance on medications that have not demonstrated clear benefits for the disorder's core symptoms. Clinicians are encouraged to conduct regular medication reviews and tailor care to the individual needs of the patient.
If you've been using antipsychotic polypharmacy to treat schizophrenia, I've got some new findings here that might change how you practice. These two new studies from the SWAP trial, that's Switch Antipsychotic Polypharmacy Trial, were published in Schizophrenia Research, and they suggest that switching to monotherapy could offer these patients significant benefits. Our first study took place with long-term inpatients with schizophrenia, 136 in all. These patients were randomized to two groups. One group continued with the antipsychotic polypharmacy, and the other group gradually switched to a single agent. Surprisingly, the relapse rate was lower when the antipsychotics were reduced. Over 9 months, those who transitioned to monotherapy had fewer psychotic symptoms and a 29% lower risk of relapse. Astonishing when you consider that we're taking an antipsychotic away in a randomized fashion. Outcomes were best for those who stayed on clozapine as the single agent. The second paper looked at adverse effects as they took antipsychotics away in the SWAP trial. Patients who switched to monotherapy saw significant reductions in movement-related side effects like akathisia, Parkinsonism, and dyskinesias. They also had improvements in BMI and weight. Additionally, symptoms like depression and gastrointestinal issues improved significantly for those who had their dosage reduced to monotherapy. However, there was no noticeable change in sexual and neurologic side effects between the two groups. These findings suggest that moving from antipsychotic polypharmacy to monotherapy, particularly when that monotherapy is clozapine, can reduce relapse risk and alleviate multiple side effects without compromising symptom control, at least in this population that they studied of long-term hospitalized patients. Focusing on single effective medications could enhance safety and improve the quality of life for your patients with chronic schizophrenia. It reminds me of another study where giving too many or too high doses of antipsychotics increased mortality rates, as did very low doses, but sticking right in the middle led to the longest lifespans for people with schizophrenia. If you're treating patients with opioid use disorder, we've got some encouraging news about the use of telehealth. There's a recent study from Oregon and Washington that found that patients receiving buprenorphine through a fully remote telehealth platform were significantly less likely to discontinue treatment compared to those in traditional office-based settings. Here's what really stands out. Over a 24-week period, patients who used the telehealth-only platform had a 61% lower risk of stopping buprenorphine than those who received in-person care. Now, both groups were similar in that they both had reductions in substance use behaviors and cravings over time. This study suggests that telehealth could be a viable alternative to in-person care for buprenorphine treatment, as it improves retention, a life-saving factor for these patients. Telehealth may bridge treatment gaps for patients who are facing barriers to in-person appointments, and these findings advocate for maintaining telehealth options for opioid use treatment, something that the DEA is considering as we speak. Future research could help us identify which kinds of patients are going to benefit most from a hybrid approach versus a purely telehealth approach, contributing to broader, more accessible treatment frameworks in addiction recovery. There are a lot of changes to buprenorphine treatment recently, and the removal of the X waiver means that all people who prescribe and hold a DEA license are expected to know how to use it. To learn more, check out our October issue of the Carlat Report, where Dr. Noah Caporso discusses recent regulatory changes and gives a simplified algorithm to starting and managing buprenorphine medication.
According to recent large-scale trials published by Intracellular Therapies, lumateperone may be an effective treatment for depression with mixed features in both bipolar and unipolar disorders. You might already know lumateperone as an FDA-approved medication for bipolar depression, but this study explores its potential as a standalone treatment for major depressive disorder and bipolar depression when mixed features are present. This could offer us an alternative to traditional antidepressants, which often aren't effective and can worsen mood in mixed depression. The trial involved 383 patients who either had MDD or bipolar depression accompanied by mixed features, symptoms for both manic and depressive states. Over 6 weeks, patients treated with lumateperone showed significant improvements in depressive symptoms compared to those who received a placebo. The effect size on the MADRS ranged from 0.6 to 0.7. Importantly, these improvements were consistent across both bipolar and unipolar groups, suggesting that lumateperone has broad potential. Mixed features, where depressive episodes are accompanied by symptoms like irritability, impulsivity, or agitation, are more common than we might think, affecting about 25% of depressive cases. Unfortunately, traditional antidepressants can sometimes make these symptoms worse, increasing impulsivity and agitation. Because mixed depression can resemble anxiety or other conditions, accurately diagnosing this is crucial. Asking patients about their sleep patterns, impulsivity, and energy levels can help uncover mixed states, even if they don't identify as manic. In such cases, mood-stabilizing antipsychotics might be the preferred treatment option. This study adds to a growing body of evidence that standalone antipsychotics may effectively manage the complexities of mixed depression. Given the prevalence of mixed features and the associated risks of impulsive behaviors, using an appropriate mood-stabilizing treatment could significantly improve patient outcomes.
There's encouraging news from a new systematic review published in Schizophrenia Bulletin Open that offers valuable insights into patients' experiences with clozapine for treatment-resistant schizophrenia. If you've been hesitant about prescribing clozapine due to concerns over side effects and monitoring requirements, then this information might help you reconsider. The review analyzed data from 13 studies involving over 1,400 patients, and the majority reported positive experiences with clozapine, especially in managing symptoms and improving quality of life. Across multiple studies, 58 to 90% of patients expressed satisfaction with clozapine, and many noted improvements in mood, reduced anxiety, and better cognitive function. Patients also mentioned better sleep and an increased ability to socialize. Notably, compared to other antipsychotics they've tried, most preferred clozapine, even when considering its side effects. Many were willing to tolerate issues like hypersalivation, weight gain, and sedation because the therapeutic benefits made a significant difference in their lives. But of course, not all feedback was entirely positive. Some patients found the regular blood monitoring necessary to prevent rare but serious blood-related side effects to be burdensome. And side effects such as hypersalivation, weight gain, and sedation were challenging for some, but these were often viewed as self-manageable trade-offs. Hearing directly from patients that they find clozapine more effective and satisfying than other medications may encourage you to discuss this option more openly with those who could benefit. And despite the side effects and monitoring requirements, patients generally find clozapine manageable and worth the benefits that it provides. So by sharing these insights and engaging in shared decision-making, you may help more patients access a treatment that could significantly improve their quality of life. Given that clozapine remains the most effective medication for treatment-resistant schizophrenia, considering it earlier in treatment plans could make a real difference. For patients struggling with symptom control, clozapine can enhance both their well-being and adherence, especially if side effects are effectively managed and discussed in a supportive setting.
A new study published in Psychological Medicine explores whether patients with binge eating disorder who respond to lisdexamfetamine, Vyvanse, should continue with the medication to maintain their improvements. This is the first placebo-controlled trial to assess lisdexamfetamine as a maintenance therapy for binge eating disorder after initial successful treatment. They started with 61 patients who responded to lisdexamfetamine after 3 months on the drug. They were then randomized to either continue with the drug or switch to a placebo and then were followed for another 3 months. The switch was done over a 4-day taper. Here's what they found. Binge eating relapse rates were not that much different. 10% for those on lisdexamfetamine versus 18% for those on placebo, but it was not statistically significant. However, patients continuing lisdexamfetamine showed additional benefits in weight control, with an average weight loss of 2.3% compared to 2.2% weight gain in the placebo group. The lisdexamfetamine group also maintained stable scores in eating disorder-related psychological symptoms, while these scores worsened in the placebo group. While continuing the medication didn't significantly reduce binge eating relapse, it did appear to help with weight management and psychological well-being. The bottom line, continuing lisdexamfetamine beyond 3 months leads to very small gains, and those gains need to be balanced against the risk of known cardiac and psychiatric risks of amphetamines.